So my name's Kush Desai. I'm one of the curriculum deans at the Southwest Medical Georgia, or Southwest campus for the Medical College of Georgia. I'm also part of the hub team for the Georgia Colorectal Cancer Control Program, ECHO. So that we can get to know each other. I know many of you have already done this already, but you can put your name, the name and affiliation of your clinic or your academic institution, and your contact information as your email in the chat box. And we really appreciate that. If you have more than one person in the room with you, please put the name of everybody in the room with you, so that way we can accurately count our attendance and our participants. So next slide, please. Actually, this is today's agenda. We'll first start with an introduction. Then we'll go into our expert presentation by Dr. Durado Brooks. And following that, we'll have our case presentations. We have providers from APHC's Rural Model Clinic. This is Melissa Stevenson, Alyssa Koopal, and the clinic manager is Kendall Guthrie. And they're all with the Albany Area Primary Healthcare, which is an FQHC in Southwest Georgia. We also have Brenda and Christopher who are managing the controls. Next slide, please. So this is this platform that we're utilizing. It's called Project ECHO. It stands for Extension for Community Healthcare Outcomes. Next slide, please. So just a few housekeeping items. By participating in these sessions, we are being recorded. Also, please don't include any health or any patient PHI in our discussions, since these are being recorded. Next line, please, or next slide, please. We do collect data as far as registration and participation, mostly for quality improvement and for research purposes. Next line, please, or next. All right, just some general Zoom reminders. I know we've all been using this online platform for a while now, but just as a quick reminder, please keep your microphone muted. And when you're not talking and when you're talking, please remember to unmute. If you are able and your bandwidth allows it, we would love to see everybody's faces, but if not, we fully understand as well. Next slide, please. All right, so I'm going to present to you our speaker. This is Dr. Durado Brooks. He's the Associate Chief Medical Officer for Screening at Exact Sciences. Dr. Brooks joined Exact Sciences Corporation in October 2020 after a 20-year career with the American Cancer Society. Throughout his ACS career and in his current role with Exact Sciences, Dr. Brooks has worked to increase access to high-quality prevention and screening and to decrease cancer-related inequalities at the nation, state, and local levels. Before joining ACS, Dr. Brooks provided primary care and served as a medical director for community health centers in Ohio and in the community-oriented patient primary care program in Dallas, Texas. So without any further ado, I'm presenting to you, Dr. Brooks. Brooks, you can take it away.
Great. Thanks so much, Dr. Desai. And thanks to you all for inviting me to be part of this. Next slide, please. So as was already mentioned, I am a full-time employee of the Exact Sciences Corporation. We're the makers of multi-target stool DNA testing, or better known as Cologuard. However, today's presentation will not include any information specific about Cologuard or other colorectal cancer screening modalities. It's really about vulnerable populations, health equity, and how a few tips at the end about how to address some of the challenges. Next slide, please. Next slide. So start off with a few definitions. When we talk about health equity, the definition that I like, and this is based, I believe, on the Robert Wood Johnson Foundation definition, and that is trying to provide a situation where everyone has a fair and just opportunity to be healthy. And this requires removing obstacles that prevent people from being healthy. And we'll be talking about some of those obstacles in more detail. When we talk about disparities, there are a couple of different kinds of disparities. There are health disparities, which are differences in incidence, prevalence, mortality, burden of disease between different populations. And then there are healthcare disparities, which often lead to those health disparities. And healthcare disparities are differences as they relate to the healthcare system. That is, people's access to care based on things like insurance coverage, quality of care, and other factors. And then the populations that are impacted in these ways that experience various health equities are multiple. Next slide, please. So examples of vulnerable populations, and this is by no means an exhaustive listing, unfortunately, but certainly individuals who face financial insecurity for any number of reasons have a higher risk of all kinds of health outcomes. And while I'll be talking with some specificity today about colorectal cancer, you can substitute heart disease, diabetes, and negative outcomes, or a host of other things. And these same populations come up over and over again as those who suffer disproportionately. So individuals who have difficulty with transportation needs are a vulnerable group. Certainly race and ethnicity, the uninsured, people who are experiencing homelessness, people who live in rural environments, as well as elderly individuals. Mental health, that's a group that's often overlooked, but has a large number of health disparities. And then members of sexual minority groups as well. And all of these groups, next slide, tend to be impacted by what are known as the social determinants of health. And again, these social determinants line up with some of the points that were made earlier with regard to the underlying causes of inequities. And those include things like economic instability, educational differences, the context in which one lives, the social and community context. Certainly access to healthcare in neighborhood and built environment. And you can see on the right all of the different ways in which social determinants can have an impact on longer term health outcomes. Next slide, please. So while there are, again, a lengthy list of things that can contribute to health inequities, the number one predictor of life expectancy in the US is the county in which one lives. Next slide. My former boss used to say that when it comes to cancer and really other health issues, that zip code trumps genetic code. So even individuals who have family history of cancer, heart disease, et cetera, depending on where they live, the way that plays out can be very, very different. So here's just one example. If you look at the average life expectancy of a child born in 2014 in the US overall, the average that child is likely to live to just a little over 79 years. If that same child is born in Adair County, Oklahoma, their lifespan is likely to end after 56 years and change. Whereas if they're born in Chatham County, North Carolina, their average lifespan is 97 years. So we're talking about a 40+ year gap, depending on where one lives. Next slide, please. And this is just shows that even though when you look at Chatham County, for instance, on the left there, the darker areas are areas with higher life expectancy. The lighter areas are those with lower life expectancy. And even within Chatham County, which has those very high life expectancy rates, there are areas where those life expectancy rates are significantly lower. And similarly, Adair County, they're on the right, even though they've got areas with very low life expectancy, that's where it was only 56 overall for individuals born there. There are other parts of that county that have much higher levels of life expectancy. Okay, next slide, please. So shifting gears now and talk a little bit about colorectal cancer and colorectal cancer screening. Next slide. One of the things that we know about colorectal cancer is the huge difference that screening can make in terms of outcomes. This study from Kaiser, which has one of the best colorectal cancer screening, probably the best colorectal cancer screening in the entire country, they looked at colorectal cancer deaths in their population and found that between 2006 and 2012, of those individuals who died of colorectal cancer within the Kaiser system, 76% were not up to date with screening. So 24% of people who died had gotten screened, but 3/4 of those who died were not up to date with colorectal cancer screening. We know, next slide, please. We know that colorectal cancer screening makes it makes a huge difference in the stage of disease at diagnosis, and stage of disease is linked very closely to outcomes. Here on the right, the 5-year survival for an individual diagnosed with colorectal cancer in stages 1 or 2, early stage disease, 91%. 9 out of 10 patients who are diagnosed with that early stage disease are going to be alive 5 years later. Contrast that with individuals who have stage 4 disease, metastatic disease. At the time of diagnosis, only 15% are going to be alive 5 years later. 15% versus 91% 5-year survival. And yet, if you look here on the left, only 34% of patients, basically a third of patients, are found during that earliest, most treatable phase. So we're letting a lot of people be at high risk and end up dying from a disease that we can either prevent or find early and change the course of disease. So that's why colorectal cancer screening is such a passion project for me and for many of us who work in this field. Next slide. If we look at the nation overall, how are we doing in terms of colorectal cancer screening? This slide is from 2018. This is CDC data from 2018 looking nationwide. And about 2 out of 3 people who should have been screened at that time based on guidelines at that time. About 2 out of 3 people were up to date. Realize though that the guidelines then largely said screening starts at age 50. You know that has now shifted. So, but even looking only at the 50 plus population, 1 out of 3 people who should have been screened were not up to date with screening. Coming back to social determinants and the fact that zip code trumps genetic code, you can see that even looking across the country, there's tremendous variation. You look in the Northeast, New Hampshire, Massachusetts, Maine, you're looking at screening rates overall in the 75 to 77%. So very close to that 80% goal set by the National Colorectal Cancer Roundtable. Then you come to the South and look at my home state of Texas, 60% of people up to date with screening. Georgia, a little better, 68%, but really very close to that national average. So again, we're looking at anywhere from a quarter to a third of people in each state across the country not being up to date with colorectal cancer screening. And that's not including the new population that should be screened of 45 to 49. Next slide. If we then shift gears and look specifically at federally qualified health centers, which are very widely represented here, then you see that the numbers are even more concerning. Within FQHCs, and this is from 2021, so more recent data than what I just showed you, but you can see that only about 42% of at-risk individuals in the 50 plus population were up to date with colorectal cancer screening in 2021. Again, your UDS measures are changing, and you're going to be looking at that 45 to 49-year-old population. So that 42% number is likely to fall. But again, you see that there's very significant variation from state to state, with, again, those states in the Northeast now, topping 60%, whereas looking in the South and specifically at Georgia, only 31% of FQHC patients were up to date with colorectal cancer screening. So a long way to go. Next slide. If we look beyond geography and look at some of those social determinants that I mentioned earlier, things like age, you can see that in general, this is one place where younger populations tend to do worse. So younger populations, the 50 to 54-year-old population, only about 48% of those folks were up to date with screening back in 2018 based on that CDC data. So even though screening had been recommended for individuals beginning at age 50 for more than 20 years, half of folks in that younger age group weren't up to date with screening. Race and ethnicity, you see significant variation. Education, those with lower educational levels, much less likely to be up to date with screening. Immigration status was another big predictor, with those who've been in the country fewer than 10 years having much lower rates of screening. Income played a big role, and the lack of insurance may be the most important factor, with screening rates among the uninsured only about half those that we see in the insured population. Next slide. But even when we look at race and ethnicity, you can break that down even further. And if you look, for instance, at the Hispanic Latino population in the US, depending on their country of origin, there's significant variation there. So that individuals who are Puerto Rican Hispanic had much higher screening rates than those who are Mexican Hispanic. So you really have to look at the data very closely to understand the populations and where the potential barriers are in order to help overcome those barriers. Next slide, please. All right, one more slide. So let's switch now and talk. We talked about screening. Let's talk about the outcomes of colorectal cancer. And this slide shows tremendous variation in both incidence and mortality of colorectal cancer by race and ethnicity across the US. And while many people have long said that African Americans have the worst outcomes, the reality is that when you look at incidence rates, for instance, American Indian Alaska Natives actually have higher incidence rates even than the African American population. And if you look at mortality, the mortality rates are very high among that group as well. And then variation among other groups. Next slide. But it's not just race and ethnicity. If you look at rural versus urban, for instance, individuals who live in rural areas have a 23% higher risk of dying from colorectal cancer than urban dwellers. If you look at financial insecurity, individuals, I already mentioned being uninsured is associated with a much lower likelihood of being up to date with screening, but also a much higher risk of being diagnosed with later stage disease, as I already pointed out, has significantly worse outcomes. Next slide. And then there are some things we don't have a real clear understanding of, such as the fact that for African Americans, even when they are diagnosed at the same stage as their white counterparts, their outcomes tend to be worse. The gray bars here are African Americans. And if you look at individuals, the orange bars are the white population. And you can see for localized disease that individuals who are diagnosed with colorectal cancer, the white individuals who are diagnosed with localized disease have a 91% 5-year survival rate, which I mentioned earlier. But for African Americans, that rate is 88%. For regional disease, again, a 73% 5-year survival for the white population, only 68% for African Americans. It's believed that a lot of this comes down, again, to some of those social determinants that were mentioned earlier, in particular, access to care and the quality of care that's provided to African Americans versus white patients. Next slide. And then you see similar differences in the American India, Alaska Native population as well, with American Indians having lower survival rates with localized and regional disease than the non-Hispanic white population. Next slide. So how is it that social determinants, that social factors can lead to different outcomes? And this is one hypothesis. This is a schematic developed by John Carruthers, who's currently the president of the American Gastroenterological Association, and Chaik Devaney, who's a researcher and a health equity scholar at Ohio State University. And their hypothesis is that, starting on the left, living in an environment with lower socioeconomic status, lower levels of education, difficulty accessing healthcare, then has downstream consequences. So those individuals live in lower income neighborhoods, have lower paying jobs, They end up working several jobs, meaning that they don't have time to go to the doctor. They live in grocery store deserts. They have poor access to high quality food, and they're more likely to be impacted in their environment by tobacco, alcohol. And then all of these, shifting further to the right, have actual biologic consequences in the colon. So changes in the gut microbiome, local carcinogenic byproducts being increased higher colonocyte proliferation. So there are actual theories and models that demonstrate that being poor and having lower educational level has physiologic impact on your body. So it's beyond just the social. Next slide, please. So one more slide. So wrapping up, the basic point here is it's important to recognize the various factors that are putting your patients at higher risk of developing and dying from colorectal cancer. And recognizing that vulnerability looks different in different patients. So you really have to be attentive, and how you address those vulnerabilities is potentially going to be different in different patient groups as well. The National Colorectal Cancer Roundtable has developed a number of messaging guidebooks that have taken a deeper dive into specific populations, so rural populations, African American, Asian, Hispanic, and done message testing to try to assess what kind of messages are most impactful to help individuals begin to think about getting screened for colorectal cancer. Next slide. So again, you have to look at what barriers are causing your patients not to get screened, and then look to specific guidance from NCCRT or other places in the medical literature about how to address whatever those barriers might be. Next slide. These guidebooks are really helpful at helping to identify what kind of factors can motivate patients from different backgrounds facing different barriers. And then next slide, they have very specific focused messages for different groups to help you talk to your patients in a way that they can understand and listen and potentially react more strongly and more positively to the message you're trying to provide. Next slide. And one more. Exact Sciences has created what we call the Exact Academy that has a wealth of information and resources about colorectal cancer screening, and various kinds of colorectal cancer tests that are available. And it can be accessed by scanning the QR code that you see here or visiting exactsciences.com/Exact Academy. So if you want to take a deeper dive into colorectal cancer and colorectal cancer screening, this is a good place to start. And then for the NCCRT tools and resources, I mentioned nccrt.org, and then go to their resources tab and just type in guidebooks or messaging, and you'll find a wealth of information there, as well as probably 100 other tools and resources to help with colorectal cancer screening improvement. All right, thank you all very much. And I am happy to take questions you tell me what happens now, Alyssa.
Yep. So that's correct. So thank you for your presentation. First of all, that was excellent. I mean, those of us that are providers, like we deal with work with all kinds of populations, but then actually seeing the actual statistics of the disparities was just fascinating and really eye-opening for me. Especially working in a rural area and with diverse patient population. I think many of our providers work in the same rural areas with a very diverse population, and I think it's just cool to see the actual numbers, and it's motivating to really help those patient populations specifically, I think. And so that was my feedback and at least my interpretation. What about others that are on the call that are also providers from different regions from all over Georgia, but really all over the country? That any questions or comments from you guys? I see a hand raised. Dr. Hotz has his hand raised.
Thank you, Dr. Brooks, for an outstanding presentation. And I know you're going through a little grief having had your alma mater, Ohio State, get beat by our Georgia Bulldogs. But on a more positive note,
Couldn't let that go, could you, Jim?
couldn't get by it. One of the challenges when we co-chaired the Community Health Center Committee, the National Roundtable, and Dr. Brooks and I did that for about 10 years, the biggest complaint we got was, what do we do with a positive fit test in an uninsured patient? And it absolutely discouraged people from participating. And it's interesting, as you look at the state map, there's a pretty strong correlation between lack of Medicaid expansion and really poor rates. I have wondered, because we're right now trying to go to our legislature, trying to expand Medicaid. It's a big issue in Georgia and a lot of these states. Has anybody developed I mean, you can use the UDS numbers and over time and look at the, as the Medicaid expansion goes to states, what happened to the numbers? Has anybody developed that? Because we'd like to have a very well validated tool that you could go to legislators and say, listen, people are dying of colon cancer. Now we know breast cancer and others, but it seems like with the UDS numbers, it'd be great. And I know you spent a lot of time at ACS as well. Do we have those numbers any place and where we could, craft that argument?
A couple of different things come to mind. One, ACS CAN, the American Cancer Society Cancer Action Network, publishes these sort of state by state and district by district booklets to help with those kind of localized arguments for increasing funding for cancer screening and follow-up. So I think that ACS CAN data would potentially help you look at that, and looking at the trends over time, particularly since the Affordable Care Act kicked in, we know when various states started expanding Medicaid. And there have been a couple of papers published also that showed that in states that expand Medicaid, you start seeing a dip in colorectal cancer deaths. So that's one option. And that there are some specific states, about the work that's gone on in Kentucky, for instance, that was a little late to expand Medicaid, but really has kind of put a full court press in place. And I think that talking with some of the folks there in Kentucky, Whitney Jones, or I forget who works with him from a lobbying legislative standpoint. But I think that I know early on that they were collecting that sort of data as well to help bolster their argument to their legislators to continue to support Medicaid expansion and colorectal cancer screening programs in particular. There's certainly at Exact Sciences, we're working with one of the GI organizations to try to put together a pilot project demonstrating this kind of the positive outcomes that we know are associated with bridging that final gap, because there is reluctance to screen someone with a stool test if you know that your ability to access colonoscopy is limited. But also right there in Georgia, you all have begun to build a network to try to help close that gap as well. And I think that the data that you all are able to collect over the next year or two is going to be beneficial.
Thank you.
Yeah, thank you, Dr. Brooks, and thank you, Dr. Hotz, for the question. We're going to get started with the next section. If anybody has more questions, please keep those in mind. You also can put them in the chat box. We'll have another opportunity for questions after the case presentation. But I wanted to make sure that our case presenters are also able to give their talk. So for our case presentation for today, it's Albany Area Primary Healthcare. We have two providers and the clinic manager for Rural Clinic, which is one of the clinics in part of that FQHC. Their case study is titled Equity and Disparities in Screening Rates. We'll have 10 minutes for the case topic discussion, and then we'll have more time for questions after that. So the AAPHC providers, you guys can take it away. Do we have
Kendall? Okay, well, So my name is Robbie. Good afternoon, Robbie Amin. I am the clinical liaison for the Georgia Colorectal Cancer Control Program and work closely with the providers here at the rural clinic. So I'm just going to quickly do the introduction and then jump into Kendall, and then I'll do some data in the middle. So on the next slide, please. So these are the providers that we have at the rural clinic. Alyssa Stevenson. Yep, next slide, please. Alyssa Koopal, next slide, please. And the operations manager, Kendall Guthrie. So Kendall, I'll throw it to you, and so you can tell everyone about the rural clinic.
The rural clinic began in 1990. There's a recognition by that point of the growing number of HIV/AIDS cases in our rural area, and a lot of entities that were providing services at that point in time from 1981 when the epidemic first started until that point were mainly focusing on outreach, screening, and testing. By 1990, there was a new direction to start to look at ways to treat. So we provide comprehensive primary care and HIV/AIDS specialized care to HIV positive individuals. We provide care to over 80% of the individuals that are diagnosed with HIV/AIDS in Southwest Georgia. And 89% of our patients are at or below 100% of federal poverty level. We do have a sliding fee scale. We're able to, as an FQHC and a Ryan White HIV provider, we're able to look at the federal poverty level and to take into account where people fall on that scale, and then in turn determine how much of the responsibility. Ryan White, of course, is a part of the Health Resource Service Administration. As part of many parts of their Ryan White program, is always the payer of last resort. So we've been very successful identifying the individuals who fall into that category and keep us compliant at the same time.
So I'm going to take it back from Kendall for a second, just to go through some data for the clinic. So next slide, Selma. So just a background of the demographics that we're dealing with. This is in the age group for colorectal cancer screening. That's the total population is about 512. The total population currently in the 50 to 75 is 373, with 224 being men and 149 being women. The uninsured population is of those 92, as you can see in the charts. And the screening rates are so given next to it. Next slide, please, Selma. So these are really the highlight of what I wanted to go over for the data aspect of it. This one in the next slide, showing the number, just showing that the rate, as you can see during COVID, was 49.22%. And this is at a specialty clinic, an HIV clinic, as I'm talking about. And then it went up the year after several, a lot of intervention. The rural clinic actually joined the grant in August of last year. So we got a big bump towards the end of the year, and that gave us, we ended with 64%. And they hit the ground running this year. And the current rate, where the last rate we have is from November numbers. They're currently doing December, where they ended with an average of 66.22. Salma, if you go to the next slide. This is the trend from last year, from 2022. As you can see, again, started at 60, a little bit lower, then it went up, but it's been progressively been going up and up. And as of November, 67.12%. Now I'm going to give it off to the providers for them to explain how they got here and what they do to get to this level. Next slide, please. And Alyssa, take it away.
I'm Alyssa Stevenson. I'm a nurse practitioner at the rural clinic. So as far as our screening process, we do have medical assistants and LPNs here that do pre-screen the charts and notes for patients prior to the visits. And they also discuss the colorectal cancer screening in the triage process. After that, they will notify us and we'll discuss it with the patient. We'll educate them. If they don't feel comfortable with the screening or don't want it at that time, we'll continue to discuss it. Sometimes they might not do it at that visit, but they will agree to it at the following visits. And we'll continue, it's like it says, reiterate screening, and most individuals will end up at least taking a fit test. If accepted by the patient, our referral is sent to Horizons, and they continue to navigate the patient from there. If they're a positive fit test, they also navigate to a colonoscopy. Next slide, please.
Yeah, and my name's Alyssa Koopal. I'm one of the PAs that also works over here at the rural clinic. And main barriers we face are definitely the process of collecting a stool sample. I do think one thing that we can kind of convince patients to do it is that they're able to do it at home. So a lot of people feel more comfortable with that as opposed to having doing it in office. So we'll just send them home with the envelope. Our nurses are really good about going over the whole procedure with them. And then we also have the Horizons person who calls them to make sure that they don't have any follow-up questions with how to actually do the stool sample, but also mail it to the lab for processing. And then, as we know, a lot of patients do end up deciding to do the stool sample because they're apprehensive about doing a colonoscopy. A lot of times I hear patients say either like the invasiveness, or they've had a family member or a friend who had done one, they had something go wrong. So sometimes we usually try to encourage that one, but if not, we usually are able to get most of our patients to at least complete a fit. And then along with the fit, kind of what I was going back to at the first point, a lot of people do sometimes say that they either lost it or they forgot to do it, or they have it sitting at home and now it's outdated. So there are some things probably still to be improved on that end. But in general, we do have good follow-up with that, and we usually have pretty good return numbers. I think that's main points on there, yeah. And then on the flip side, reasons for success is definitely that first one's a main thing with our clinic. We have everyone from our nursing staff to our providers to our lab to Horizons who are all helping in every step of that process. And we try to prioritize it. It's nice being a specialty clinic because we're able to focus on it a little bit more. Sometimes in primary care, it kind of gets lost if they have a lot of issues going on. But with being a community health center, it's one of our priorities that a lot of times our patients, they only have transportation for that one visit, or they can only afford that one visit. So we do try to get as much accomplished on that one visit as we can, and definitely prioritizing all cancer screenings, and especially colon cancer screening is a huge point for all of our providers here. We also, Melissa and I both document everything in our charts in the same area. That helps a lot because sometimes things can get lost in EMRs pretty easily. So each visit when we have a patient come in, we're looking in the exact same area each time. For all of their cancer screenings, we usually put their most recent one, what the results were with their recall. So all of that kind of helps navigate it for ourselves, so we know exactly when people are going to be due for that next one. And next slide. And then Kendall,
Yeah, so this is a campaign that we just started just before the holidays. One of the things we wanted to do was to really encourage our men patients, our male patients that are coming in, and sort of do a mini target focus on males. And so we, our CEO, Shelley Spires, came up with the idea to purchase these kits that are shave kits. A lot of our patients are at or near poverty level, and many times facing unstable housing and homelessness. So we find that doing little campaigns like this can spur people on to do something that they maybe wouldn't normally do. So we advertised this. I just basically did a real basic thing and took a picture of the kit and then did a little slogan at the bottom: complete the fit and get a kit. And so we're going to be going along with this for a little bit and see if it makes any difference.
All right, thank you guys. That was very interesting, especially working with such a specific population and still being able to get their screening, focused. And so that, and I like that kit idea. Kendall, can we see that kit again? So it's basically a shaving kit you guys are giving to.
It's a Harry's kit.
Wow, that's
Got
nice.
shave cream and a razor. And it just comes in a little box, and just every man deserves quality craftsmanship, simple
Yeah.
design and such.
Have you guys started that program yet?
Yeah, I just got the flyers out in the waiting area. I'm hoping to see it be productive, do a little bit more communication with our staff about it, and see if we can, give a little boost to the numbers.
Yeah. That's great. Yeah, we'd love an update maybe in the next session, echo session, to see how that's going.
Sure thing.
Yeah, Dr. Desai, I'd like to make one comment
Sure.
about something that was not emphasized in the slide. It was the very last thing where it said trust. This clinic was the first rural clinic in the country. It was developed by people with HIV for people with HIV. Every one of those issues that Dr. Brooks talked about, rural, minority, especially Black, LGBTQ, homeless, mental illness, transportation issues, lack of insurance, every one of those issues fall on this population. What has happened through the years, because of the frequent visits, the amount of support with social workers, mental health, the tremendous team we've got there, they've been able to develop this trust relationship and have gotten people to realize that, with 90% having no viral load now, they're more likely to die of a chronic disease other than HIV, and have got them to kind of turn their vision to become like, somebody who did not have AIDS. And because of the trust and helping them manage their HIV condition, they've been able to translate that into getting people to aggressively take cancer screening, because their breast and cervical cancer rates are also extremely high. And so, sometimes it seems hopeless when we look at all those social determinants that mount, but when you look at a very strong relationship with a lot of resources to overcome adverse social determinants. And by the way, the colonoscopies are 100% paid for the uninsured because of another program we've had with our local GI group. What it does show is you can accomplish pretty amazing things to address them, but it does require, a resource intensive program with a clinical staff that has very strong champions that are pushing these issues. So I just wanted to emphasize the fact that once you develop that trust relationship, what used to be thought of as the lepers of today's society, now become into that big tent of healing and health. And so it's pretty amazing accomplishment for the team over there.
Yeah, that's an excellent point. I think we also have some poll questions for the audience. Brenda, can we? Yep, there we go. So this is kind of based on Dr. Brooks's presentation. It's not. Let's see. There's a way. Is there a way to actually answer the questions? There we go. Yep. So we're just asking, which vulnerable population do you encounter the most in your clinic? So I was seeing there's clinics represented, of course, throughout Georgia, but also throughout the country. I mean, I saw there was like a program in Nebraska, a program in Kentucky that was represented, a program in Kansas. Yeah, so it looks like of most of the people on this call, it looks like people without insurance or underinsured patients are the ones that are they're having the most difficulty. And then that goes along with people facing financial insecurity, because that's also, of course, if you're without insurance, underinsurance, most likely you're going to have financial insecurity as well. It's very interesting. Do we have the next poll question? we ended up with 65% of our participants on the call have patients that their number one issue is insurance. And this is our next question. So it's easy to recognize your patient's social vulnerabilities. So this is something that after Dr. Brooks's presentation, just like I was saying, like it's motivating to see those actual disparities and the data behind it. And you know, a lot of times we're busy in clinic or in the hospital seeing patients, but from y'all's perspective, what do you feel like? Is it easy to recognize patients' social vulnerabilities? Looks like we have a kind of a split. We have 45% to say agree, and then the remaining are either neither agree or nor disagree, or disagree or strongly disagree. Very interesting. So any providers, I mean, yeah, I've kind of been saying my own experience, but any other providers, as far as identifying these patients' social vulnerabilities, I mean, is this something that that y'all tend to do a lot, or is this something that we find is difficult? So maybe we can start with some of our providers from other states. I see there's let's see that we have somebody from Kansas. Sorry, I'm just picking on people, but I think it is important to have feedback from people from all over the country. So is there a Sandy Siebert from Kansas Department of Health and Environment? Still on the call?
Yeah, can you hear me?
Yes, thank you for joining us.
Yeah,
From your work, what's any feedback or any comments?
yeah, I think we did some clinic visits this summer, and in far western Kansas on the Kansas-Colorado border. It's actually a frontier, and so there's large feedlots out there with a lot of especially Hispanic workers, and so a lot of probably more underinsured that potentially aren't set up with primary care just because I'm not getting tested at all.
Yeah, that's I think a big concern. So these are patients, these are like farm workers or
Yeah.
yeah. And so I'm going to pick on another person from actually from Georgia. I also work with a big farm worker population. And so thanks for that feedback. So from Reedsville, I think Coy, I think if I remember, when I went down there, y'all were saying you guys work with a lot of, you guys work with farm worker population as well. Are you on the call, Coy? For Reedsville, East Georgia Healthcare Clinic?
Yes, I'm here.
Yeah, what are y'all's comments on just patients with social vulnerabilities down there?
Well, yeah, we have a lot of farm workers. Some of them come and go, though. There's seasons down here. So, I mean, if they don't bring their stuff back, then, but there's not so many in that age population. A lot of them are younger, not up to 45. There are some 45 and older ones, but trying to get them to understand the importance of it and, not to tell them that you could get a free colonoscopy out of it, but just to say that it's really important, but not without telling them it's free, they still don't think that they will have the finances to get it all done and everything like that. So that's one of the barriers, definitely.
Yeah, that's a good point. Just from what did you think of that shaving kit thing? You think
usually it
like
pulls the heck out of your hair, so it leaves more burns than not. I've tried some of them before, but if it works, you can. I don't do that, right? Yeah,
I'm
shaving my head
maybe
too.
You could use one.
You can shave your head with it too.
All right, very good. Was there a comment I was hearing in the background?
Sharon was just saying, Sharon Carter's nurse practitioner works for Ribbon. She was saying this is always the pyramid of need as well.
What your basic needs have to be met before you can, proceed to anything else.
Sure. And so you feel like a lot of your patients, I know that you guys work with a very difficult patient population in terms of, financial security down there, because every time I visit, I'm just surprised by all the patients you guys work with. So you just feel like that they're just not worried about the colorectal cancer screening because their just basic needs aren't met. Is that kind of what?
Well, but you would understand that, actually they have a hard time even getting away from the camps. If it's raining, they'll come in by a busload, but if it's not, they'll work till dark, and they really want to get the little money that they make. And, they put, and send it home to their other people. They just have, the priorities are not looking after themselves as much as maybe their other family members. So they really put themselves on the back burner.
Got you. Those are really difficult barriers to overcome. Does anybody else have any comments? We're coming up to the end of our presentation. Thank you, Coy and Sharon, for your comments. Anybody else have any final comments before we conclude our presentation for today, or our session for today?
Yeah, just real quick. One of the things that I wanted to bring up, because I know our providers here touched upon that it's a specialty clinic, and usually people, especially in vulnerable populations like HIV positive, would think that, they're not willing or wanting to get screened. They're relying or thinking more about the other problems. But as we can see, with the right motivation and with the right provider, I guess the way they go about it, they're getting really positive impact, especially with people in that population living longer. But one of the things about vulnerability that we see in other clinics in our own system is that most people, because of the vulnerability that they have, they treat our clinics like acute care rather than primary care. So one of the things that I think is huge and to talk about, and it's another discussion on its own, but at least to keep in the forefront, is how to establish these patients as make their medical home, and to have them coming back and for general care rather than just acute care for something that they need quickly.
Yeah, good point. Thank you, Robbie, for those comments as well. So, thanks to all of our presenters today, expert presenter as well as our case presenters today for spending time on giving us your perspective. So our closing announcements will be by Dr. Adhiambo. So I'm going to give the mic to her.
To claim CME credit, please follow the link posted in the chat or scan the QR code that is now on the slide. And if you had any difficulties with the CME credits for last month, we will be sending you the QR code for that. It is working right now, so you can also claim the credits for December. So thank you so much, Dr. Desai, for leading us through the presentation. And thank you, Dr. Brooks, and all the providers from AAPHC. And thank you all who offered comments and asked questions, and for completing the polls as well. And as you see, we do have the case presentation. So if you have anything that you would want to share with the group, please feel free to reach out to us at AU_CRC screening@augusta.edu. We welcome any volunteers in the clinics or even outside the GCRCCP. And for our next session, that will be Wednesday, February the 1st. This is the first Wednesday of the month, and so if you re-registered, it should be on your calendar already. And we'll be sending the information of the flyer and everything in about 2 weeks. So please be on the lookout for that. And so with that, Happy New Year. Thank you very much for attending, and we'll see you in our next session. And so please feel free to log off, and we'll see you then. Thank you.